Well, we have 10 minutes plus a little bit for any question that come from the audience. Very quiet group, yes. There's a microphone, I don't know whether, in the back, right behind you. And if you can identify yourself, we greatly appreciate it.
Hi, my name is Kim Whitmore, and I'm the director of the Graduate Health Systems Management Program for Loyola University in Chicago. And I am a former local health officer. And so from that background, I'm very excited to hear about the emphasis on prevention. But I want to just share a story of my experience as a local health officer in a small municipality. Our prevention block grant dollars to serve our entire community were $2,100, so $2,100. So when you think about the investments that we make currently, it's very difficult to really focus on prevention and public health initiatives with such little funding coming from our federal government, passing through the states to the locals. And so I hope that there are some opportunities and some really strong advocacy for shifting that funding, because one of the biggest differences in measuring value in public health is that it's not as easy to do, and it's also longer term. And so if we're focusing on a value-based system in community and public health, we need to make sure that we are able to do that a little bit more effectively and continue to invest in that.
Mark?
Just a brief comment on it sounds like your experience is very consistent with the charts that we showed in the report, and the directions related to shifting the focus of care to outcomes, to encouraging the interaction between the medical and the community-based service sector, and preserving more support for community resources like you've described are all very consistent with some of the big directions. We do want to emphasize, though, that it's not just a matter of trying to find more money, but we've really got to change the way that we're directing resources in healthcare to focus much more on outcomes and community health improvement.
Thank you.
Dr. Abbott?
I would like to comment again by saying we are under investing at the state level in public health. And I would argue that the primary reason we are under investing is because states have begun to view Medicaid as health and public health as health, and Medicaid has begun to incorporate so much of state budgets now that it has seemed like a logical thing for states to push public health away and say we're spending on health through Medicaid. The result of that is that the federal government then has stepped up and has been filling in where states have failed public health. And now that's happening at the federal level. And if you look at that graph, again on page 13, it becomes evident that the balance is different in the United States. And if you look at the results, it becomes very clear that premature death, for example, is highly predicted to social determinants of health, and it's costing us a lot of money. It's a misapplication, and it's the reason I believe where we'll see the social determinants of health come together will be in managed Medicaid plans, where states have the capacity to bring all of this together into an integrated care setting, and that we'll see potentially more public health investment when we begin to integrate it with Medicaid as opposed to use it as the reason we're not investing in it.
Right. I'll just add that I was a local health officer in the state of Wisconsin, which is consistently last or second to last in public health funding from the state level. So thank you for adding that comment. Thanks.
Thank you. I believe that the panel that follows actually will probably get into some of those issues as well. We have public health experts, healthcare delivery CEO, and others, and I have a feeling they're going to talk about this issue as well. Whose responsibility, and how do we actually do exactly what you said we should be doing? And any comments from?
I would simply add one note, and Senator Daschle can perhaps confirm this. One of the challenges, I think, historically is that the silos that exist in the Congress contribute to that absence of connection, so that the folks that worry about housing and the folks that worry about transportation, the ag committee that worries about nutrition programs, whether it's the WIC program or the school lunch or school breakfast program, there's little integration, so that when we look at essentially what in fact a service delivery ought to be, we tend not to think of that group of services, and the demands on the Medicaid program have led to essentially a greater and greater percentage of money being consumed at the state level. One of the things we'd like to begin to see is that integration, so that there's an understanding that those are contributors to essentially health care. Medicaid and managed care has attempted to do that in a number of cases. Medicare, to a certain extent, has begun to do that and looking at the duals and others. But again, you have barriers that exist that limit the number of things that you can do under those existing programs under 19 and Titles 18 and 19 in terms of what is contributing and what, in fact, those services can be. So part of the barriers we have to break down are institutional barriers within the Congress as well.
I would certainly agree with that. I guess I would say it's not only Congress. Congress has probably two areas where silos are a real problem. One is the budget, because the budget is decided separately. And secondly, the committees and the committee process and the assignments that come with it. But I would say that the executive branch is also, to a certain extent, siloed. I mean, the Department of Agriculture has the largest share of responsibility around nutrition today. And you know, you could argue that that's probably where it belongs, but how much does agriculture and HHS actually coordinate as they consider these challenges? And I don't think, you know, I think institutionally we have some real impediments there, because they're not only in different buildings, they have different budgets, they have different personnel and different agendas. And as a result, the interaction is very limited.
I'd like to put it in a more positive note, in the sense that when you look at what's now going on in communities, I think people are certainly waking up to that possibility of collaboration. If you look at our recent report on health equity, how activate communities, we have 9 examples of communities cross sectors coming together to say we can solve this problem. And what we need is what you heard is the policy and the resources to enable it to work. But I think you're going to hear from the next panel a lot of examples, which is really why we talk about activating community, that people are coming together to solve the problems. I certainly see that in my community, you know, people crossing housing and education and health working together. So I do think that we're going the right direction, but as you heard, we need to overcome the barriers and have those levers and drives to make it work. Questions?
Great. So all of you have just
Can you
touched on
identify
it.
yourself, please?
Oh, sorry. I'm Dr. Tracy Perez-Comus from the Uniformed Services University of the Health Sciences, which is the military's Health Services Institute. But for many years prior to returning to defense and domestic health policy, I worked in global health. And in global health, when we, the U.S., through USAID or through other agencies, the World Bank, where we serve as health advisors, we often preach and try to build whole of society, whole of government approaches to the conduct of health. And Senator Daschle, all of you have just touched on this important integration, that it isn't enough for us to spin and spend in the health sector without creating safe cities with sidewalks and publicly available foods that are healthy and nutritious. So I would just ask each of you, again, if there's any possibility that you can think of how we as a federal government, and I am a federal government employee, how we can work better across our domains to, because we're so siloed in our own departments and agencies. What would you recommend?
I will just restate my belief that public health is fundamentally a local and state responsibility. And a lot of what has occurred is that we have allowed the funding streams to come from the federal government, where they are very prescriptive and without the capacity, and it's been pointed out as to why that's occurred, institutionally why it occurs. But at the heart of it is, when I was governor, my first budget, 6% of the entire state budget went to Medicaid. Today, in that same state, it'll be about 22% of the entire state budget, which means it had to come from somewhere. And it came from higher education, it came from infrastructure, and it came from public health. And so at the heart of this, yes, the federal government has all of, makes all the contributions that Sheila and Tom have indicated. But at the root, we've got to get the states taking responsibility for this so they can integrate those two. I have had the same experience that you have. I've been all over the world, and I've seen us as a country talk about holistic, community-based care, and yet we don't practice it here.
A governor friend of mine once said that his role was to educate, medicate, and incarcerate, and he said they're all related. And I think there is, but I think to answer your question, I think you have to connect the dots more effectively. And I think this graph that Mike was showing, especially, is illustrative of the challenge we face. And I'm not sure many people really have connected those dots. So I think the one thing I hope we can all do is help raise the level of understanding about this interrelationship and where we fit and why it is we have such expensive health today. And I think we have a big job to do, and that's why I think VitalDirections is such an important contribution. It helps us connect those dots more effectively.
Would just highlight that the report does lay out the importance of having some clear, broad population and holistic individual focused goals, which I think does provide an opportunity to bring together different components of the federal government in supporting states and supporting communities and actually achieving those goals.
Thank you.
I would, let me first give a shout out to USIS, which is a remarkable place in training our graduate nurses and physicians for military service. It does a remarkable job in focusing on leadership as well as on healthcare delivery. But I think one of the challenges, and this goes back to the governor's point, is when it comes down to the local level, it really is the restrictions that we've placed on how dollars are used and the ability of states and communities to move those dollars around have really inhibited the kind of opportunity and the kind of development that we'd like to see, whether it's in sidewalks or bus stops and transportation plans that allow people to get to food deserts and moving out of food deserts. And I think that it has to begin at the local level in terms of responding to what those restrictions are and identifying those restrictions, and it has to come up essentially through the federal government in terms of the willingness of those agencies to begin to talk with one another. But it will be driven by budget. If you have one thing that's consuming massive amounts of money, then essentially everything else will suffer, whether it's education, transportation, whatever it happens to be. But the barriers are ones that need to be identified and broken down. That is what prevents essentially the ability to give, to have a house built a ramp for someone who's disabled. What's the challenge essentially for a food and nutrition program in a community? And I think the more that is known and understood, to the senator's point, very few people understand that linkage, and very few people understand the commitment. All they talk about is the amount of money we spend on healthcare, but they don't look at essentially the broader strategy, and I think that has to be made quite public.
I want to call your attention to page 6 of this document. The synthesis paper that talks about this exact issue, and I'll read them to you. Give states flexibility to use Medicaid funds to implement best practice in targeting most effective efforts for vulnerable, high-risk, children as well as adults, particularly risks with complex multifactorial conditions, and support states' flexible use of grant funds for technical assistance to local leadership and collaborative action working to identify and mobilize on the most important health challenges. In other words, I think we are indeed talking about more flexibility, the use of those funds to be able to implement some of the things that's being said. I can take a couple quick questions. Yes?
I don't know if it's quick. My name is Arthur Katz. It seems to me one of the fundamental issues here, and I know you've tried to reduce it to a nonpartisan issue component of healthcare, but it really comes down to the question of whether healthcare is looked at as a commodity or a right, or you're looking at as customers or patients. And the reason I emphasize that is because there was a comment about iPhones and choose between your iPhones or your medical care. Really, that's putting a tremendous burden on the patient to understand and navigate the healthcare system. And it seems to me that that's really a fundamental question. And maybe you don't want to deal with that because you want to get at some underlying issues that you think may work. But that's an underlying question that really, I think, is the basis of the conflict here.
I say that it's a very common experience of Americans that this is not an easy healthcare system to navigate. It is not consumer friendly, and I think you're going to hear more about this on the next panel, but that is why so many of the vital directions in this set of reports focused on consumer empowerment, tools that can make it easier for consumers to get the best care, to have transparency around their decisions, to get savings when they choose lower cost care. Again, these are not easy things to change overnight, but we really do see a vision for a healthcare system and for public health in this country that is much more patient-centric, and we think the way to get there is more patient empowerment.
Martina Voitis, I'm with HealthChamp. We've been talking a lot about the payer side, or how we're paying for services, but I'm curious to how much we're looking at the cost side of the cost of individual services. And when you travel the world, you find that the U.S., the cost of any individual health service in the U.S. is many times. And this is a private sector issue in the sense, because all those services are provided by the private sector. So I'm curious to see where, whereas other costs in the U.S. are not like that. Other services provided in the U.S. are very competitive in the world scheme. So it's always been a curiosity to me why the healthcare system is not like that.
I'll start. It's because we don't have a competitive marketplace, even though it's a private marketplace. And that's where we come back to the fact that the fee-for-service system requires a better organization to become a market where we're evaluating it on the basis of value as opposed to simply volume, an old phrase now, but vitally true. It's right at the heart of why this transformation in payment method is so important.
I would just add to what Mike said that my feeling is that the biggest problem we have in creating this market is the lack of transparency today. It's the only sector of the economy where at the time of purchase we don't know what it's going to cost or who's going to pay. And we have far more stats. I was watching a basketball game last night and I was reminded again, we have 1,000 times more stats on every basketball player in this country than we do on any provider in this country. And yet we're supposed to make decisions about how to spend the money, not knowing how much it's going to cost or who's going to pay. So we have a big challenge if we're going to create that marketplace in an effective way.
Well, thank you very much, Senator. I stopped watching basketball when Duke lost the other day. So let me thank all of you, but also particularly thank the panel for a great discussion.